The genus Mycoplasma contains, as far as we know, the smallest free-living bacteria. These are so small that they definitely will pass through the 0.45 micron filters. They're smaller than Campylobacter and Helicobacter. And in fact, they were originally thought to be viruses, again, because they were so small in terms of their filtration. The genome size of these organisms is very, very limited, approximately 500,000 base pairs, which is why these have been really useful in synthetic biology, if you're interested in that kind of thing. But if you're in this class, I assume you're mostly interested in medical microbiology, so we're going to talk about them mostly in that context. Uniquely among the bacteria, they do not have a cell wall. And so I want you to think about the implications of that, especially for things like diagnosis and treatment. Because cells do need some sort of rigidity to kind of help keep them together, the cell membrane contains sterols, and those provide some of that rigidity. They do grow relatively slowly, and they can be aerobes or facultative anaerobes. The most important human pathogen in this genus is Mycoplasma pneumoniae, and it can attach to the respiratory epithelium. Of course, it has some adhesion proteins that allow it to do that. It specifically likes to bind to the cilia, and remember, we've talked about how important that mucociliary escalator is. And that binding of the cell to the cilia leads to destruction of the cilia and eventual death of the ciliated cell. And that basically shuts down that mucociliary escalator and allows the bacterium to enter the lower respiratory tract. The other human pathogen in this genus, we're not really going to talk about. It's Mycoplasma genitalium. It causes infections in the genital tract. And there's a very common species that you might hear about if you're interested in birds, Mycoplasma gallisepticum, which can cause disease, especially in house finches, birds that come to your feeders, and it can affect their eyes. Mycoplasma pneumoniae can function as a superantigen, so it doesn't secrete any toxins. It itself can function as the superantigen, which one could lead to its clearance, but also can lead to a lot of the disease symptoms. The bacterium is able to rapidly change its surface lipoproteins. We talked about that also in the context of something like relapsing fever. And that ability to change surface proteins allows the bacterium to evade the immune system and potentially cause chronic infections. These bacteria, as you might imagine, colonize the respiratory tract and are estimated to cause about 2 million cases of pneumonia per year. Now, you might remember that I told you, well, we haven't got to number 1 yet, but we've talked about the number 2 and 3 infectious diseases in the US, gonorrhea and syphilis, and that I said, these are the most infectious. And number 1 is actually not Mycoplasma pneumoniae. And the reason for that is that this is not considered to be a reportable disease. Physicians are not required to report cases of Mycoplasma pneumoniae to public health departments. So this is actually considered to be one of the more common infections in the US, but because it's not reportable, it doesn't come out on a list like that, like the sexually transmitted infections, like Lyme disease, etc. So it's a very common infection. It's spread via respiratory droplets during coughing episodes, like most respiratory pathogens, often in places like classrooms or between family members. There are higher rates of infection in children simply because they're more susceptible to lots of different things. And because of that ability to change their surface lipoprotein expression, we can see the disease persist for months. Now, it's not normally a member of the microbiome, but following disease, perhaps the body has been able to control it well enough that you're no longer experiencing disease symptoms, but you are still carrying and therefore possibly able to transmit this bacterium. And so most exposed people actually will have asymptomatic carriage. So if you've been exposed to the bacterium, it's not necessarily going to cause disease, but it might start to hang out and live inside of your microbiome. The most common clinical manifestation is going to be bronchitis. So even though it's Mycoplasma pneumoniae, the most common clinical presentation is not as severe as pneumonia. But if left untreated or if the patient is otherwise compromised, it can cause pneumonia. And for whatever reason, they tend to call it walking pneumonia or atypical pneumonia. Now, this might be one of those infections that maybe you've never heard of before, or maybe you've heard of something like walking pneumonia, which makes it sound like, oh, you're walking, it's not that big of a deal. But Mycoplasma pneumoniae can be a very dangerous infection. So this is an unusual case of fatal Mycoplasma pneumoniae in a previously healthy 18-year-old woman. She went to the hospital with respiratory complaints, and she had a chest x-ray that showed pneumonia. They prescribed a fluoroquinolone, but she failed to respond. She had a very high temperature and a productive cough, meaning she was coughing up sputum. Her antibiotic was changed to a macrolide and a cephalosporin, but she continued to deteriorate. Her lungs got worse, more filled with fluid, and her liver started to fail. Despite aggressive antibiotic therapy and respiratory support, she developed hemorrhagic pneumonia and multi-organ failure and died in the hospital on day 35. Diagnosis of Mycoplasma pneumoniae infection was based on positive serology and the lack of other respiratory pathogens by microscopy, culture, and antigen testing. Although diagnosis by culture or PCR might be more convincing, this case illustrates the susceptibility of adults to Mycoplasma infections and the uncommon but well-recognized occurrence of serious complications in susceptible patients. It should also be noted that this patient most likely had an undiagnosed immune defect that increased her susceptibility to this pathogen. And so we've spent a lot of time this term talking about, well, this disease will make you more sick if you're immune compromised. This disease will make you more sick if you're immune compromised. But we don't always know if someone is immune compromised. So as a clinician, it's really important that you do take a patient seriously when they present with something that looks like an infection, because you never know, they might have an underlying immune condition that you've not diagnosed and they've not realized that could make it far more difficult to treat their infection. So for Mycoplasma pneumoniae, microscopy is not useful. They don't have a cell wall, so they don't stain with conventional reagents. The majority of staining takes advantage of the cell wall. It can be cultured, but it's slow and not available to most laboratories. PCR is very sensitive, but it's not clear whether or not it's specific. So sensitive means that it works with low concentrations, but specific or specificity means that it's going to be diagnosing this infection in particular. You really want to have high specificity and high sensitivity. And then, of course, there are some serological assays as well. Treatment would be with erythromycin, tetracyclines, or fluoroquinolones. For children, you would only really want to prescribe erythromycin. Tetracyclines in particular can stain the bones. And it might be, you might think, well, who cares if their bones are stained? But some of the bones that children have that will show up later include their adult teeth. And so tetracyclines can stain the adult teeth. And so they'll come in with stained teeth. Prevention is difficult. Isolation is impractical because so many patients already carry the bacterium and there is no vaccine available. So a couple of things I want you to think about here and that you can reflect on are, why is a vaccine not available? This is such a common infection and it can have such significant consequences. Why don't we have a vaccine? And the other thing I want you to think about is, why are our antibiotic choices so limited? What is it about the biology of this genus that makes it not treatable with other groups of antibiotics?